Hormone replacement therapy, and the new term is hormone therapy, replaces the hormones that our bodies start making less of. So it closes the gap and makes us feel better by replacing those hormones. The hormones are estrogen, progesterone, and sometimes testosterone, depending on what your needs are.
Hormone therapy and the ideas about hormone therapy has changed so much in the last 30 years. If we go back to the 1990s, doctors thought at that time that hormone therapy was really good for all women. Every woman going through menopause should take hormone therapy. They thought it would decrease the risk of heart disease, decrease the risk of dementia, just basically improve quality of life as well as decrease morbidity and mortality for women. As a result of that, the NIH set out to do a study to prove how great hormone therapy was. This study was called the Women's Health Initiative. The results of that study came out in July of 2002 with very concerning results. The results of this study was all over the news, so both doctors and the general public heard about these results, and when they came out, they said hormone therapy increases the risk of heart attack, it increases the risk of dementia, it increases the risk of breast cancer. Basically, this is bad stuff, you shouldn't be taking it. There were women flushing their hormone therapy down the toilets, not going to take it anymore. These doctors have been trying to kill us. So that was 23 years ago. Now, in the last 23 years, we've learned a lot more information. New studies have been done, and the researchers from the Women's Health Initiative went back and looked at the data and did different analysis with the data. So both in 2013 and in 2017, new results from the Women's Health Initiative came out looking at women divided by ages. So the original study looked at women basically aged 50 to 80s, all lumped together. That's where those original results came from. When they went back and divided the women up by decades, so women 50 to 59, 60 to 69, 70 to 79, and so on, they found that the women in the group 50 to 59 did not see an increased risk in heart attack. They did not see an increased risk in dementia. And depending on whether they took progesterone or not, did not see an increased risk in breast cancer. So based on those reanalysis, what I tell patients today, if you are younger than 60 years old, you have gone through menopause within the last 10 years, we do not think hormone therapy increases your risk of heart attack or stroke. The younger you are, the more likely it is that it could potentially decrease those risks. I don't feel that we have the data to say it definitely decreases those risks, so I don't promote it solely for cardioprotection or brain protection. But I think that we have enough data to say it's not going to increase those risks, and it can definitely improve your quality of life.
Most women are good candidates for hormone therapy. There are a few that are not, and that's why it's important to meet with a provider to discuss your family history and your personal history regarding hormone therapy. Certain family history would include a first-degree relative with breast cancer, but it has to be a certain type of breast cancer, and that's usually a hormone-positive breast cancer. Breast cancer in and of itself, family history does not exclude someone from getting hormone therapy. This is very important because that's a misconception that's out there. A lot of women say, oh, my mom had breast cancer, so I can't have hormone therapy. That's not necessarily true. If it's hormone positive breast cancer, we usually do not recommend that women receive hormone therapy. But if there is a family history of breast cancer, of course we recommend speaking with your provider, but it does not exclude you from getting hormone therapy. As far as a personal history, if there's a personal history of a clotting disorder, previous stroke, then you may not be a candidate. Risks of hormone therapy. Really, anyone on any form of hormonal anything, there are slight risks of blood clots, heart attack, and stroke. These risks are very minimal. Hormone therapy in and of itself when we think about it, these are already hormones that our body are producing. So when we start a woman on hormone therapy, if we start them on hormone therapy closer to when they're going through menopause, these risks are much lower. So if we start them while they're transitioning through perimenopause, the risks are much lower. If we start a woman on hormones 10 years after they've gone through menopause, they've been without these hormones for some time, that risk does increase. So our preference is to start a woman on hormones closer to when they're going through perimenopause, because it's kind of like you think about it as like a continuation of extending those hormones. So the body's not actually missing it. It recognizes that and just continues it.
The first thing I always like to talk about with my patients regarding hormone therapy is the difference between birth control and menopausal hormone therapy. Both of these products have estrogen and progesterone in them. Birth control is a very high dose of a synthetic form of estrogen and progesterone. The way that it prevents pregnancy is it suppresses your ovaries. So it goes into the negative feedback system in your brain to say, hey, ovaries, we don't need any estrogen, progesterone. We don't need to ovulate. You've got all the estrogen, progesterone that you need. And so you have this steady daily dose of estrogen and progesterone from the birth control that you're taking. Now let's compare that to menopausal hormone therapy, which is a more bioidentical form of estrogen and progesterone. Bioidentical means it's more similar to the natural estrogen and progesterone that your ovaries make. This is a very low dose of estrogen and progesterone, just meant to give you a little boost. So just meant to get your estrogen and progesterone levels up into the normal range because your ovaries aren't doing their job anymore.
They can be delivered in a few different ways. We know through studies that transdermal estrogen is safer than oral estrogen. And those can be delivered in the form of a patch that you wear on your skin or a gel that we rub on the skin. And progesterone is dosed at night in the form of a capsule, and that helps you sleep much better.
I find now versus 10 years ago, I have tons more patients on a daily basis coming in to talk about perimenopause and menopause. And I'm glad that they're coming to me because you can't get all the accurate information that you need online. But it's a good conversation starter. Hey, I saw Mary Claire Haver on Facebook and she said I should talk to my doctor about hormone therapy. I see this all the time. If your doctor is not comfortable talking about menopause and hormone therapy, and it's something that you think you need to talk about, find someone who is comfortable with it. There is the Menopause Society, formerly known as North American Menopause Society, but the Menopause Society has a database with physicians who are certified menopause practitioners. And if you live in a major city, you should be able to find a menopause practitioner in your area that you can see and talk to about it. Or, if your doctor's not comfortable with it, a lot of times they know a doctor that they can refer you to. I have a lot of the family practitioners in our area who refer patients to me because they know that I deal with menopause on a regular basis.